Most of you guys know me, but for those that don't, I'm Dr. Josh Silver. I worked here at the Pierce Clinic for about 5 years, and I learned a whole lot about the upper neck, and it was great. You know, I love upper cervical, and I helped a lot of patients get a lot better. Since 2010, I started doing the Carrick Institute, so I've been studying neurology for about 9 years. And what I knew was that eye motions affect the neck and that the neck affects eye motions, but I was never really properly trained on how to do some of the vestibular therapy. So about 4 months ago, I moved to Santa Barbara, and I've been working at ImagineX Functional Neurology since then with Dr. Harcourt, who's just a fantastic neurological expert. He's been training with the Carrick Institute and teaching there, and so he's been getting me up to speed more about how to do gaze fixation, saccades, stuff like that we'll be going over today. And that's really what it's all about, is that I would say upper cervical alone, in my experience, helps 70% of people with 70% of their problems, which is pretty great. But the 20%, the 30% that wouldn't hold would haunt me. It'd just eat me up, because I don't want to just be a good doctor. I want to be the best doctor you ever met. And I believe wholeheartedly that if we can improve eye motions, we can improve our adjustment. And if we get them adjusted, we'll affect eye motions. And that's kind of what I'm here about, guys. That's kind of what I want to cover, is that, you know, if you got a patient and you're following the protocol exactly how we teach it, and they're holding and they're not getting better, it's probably because their symptom is caused by something else, truthfully. And you know what? If you're following the protocol and they're not holding, it's not because you suck. It's because there's likely other things going on that's throwing them out of alignment. And I think that if we address those, we'll have better outcomes. You could suck, but not our doctors. So it's Monday morning, and you walk into your office, and this little girl shows up, and you take her history, and it turns out about a week ago, she was like toddling around, and she fell, and she bumped her head, and then she got a head tilt, and then she started getting neck pain. And what are you thinking? Easy case, right? X-ray her, let's get her adjusted, call her up, you send her home, say come back in 2-3 days. And she comes back in 2 or 3 days, she's out again, she's not feeling any different. You're thinking, what happened? So you adjust her again, send her home, same thing, okay? You adjust her a third time, comes back, same thing, still not doing any better, right? Why, right? You gotta do something. You gotta change something quick, or else you're gonna lose them as patients, you're gonna get a bad review. You don't want to do that, right? So all of a sudden, you flash back to this lecture. You say, what would Dr. Silver do? You take a closer look at her. Do you guys see anything going on here? Does anybody see any problems with this girl? What was that? I agree, right? Look at the space here and look at the space there, and it's high. So what do? You check her pursuits, and she can follow you for most of the time, but when you come down and to the right, that left eye follows it, but the right eye stays straight ahead. So that's not normal. I shouldn't be going disconjugate. So you try and move that eye down and to the left with a VOR, and it doesn't move. So you try and move it down with a saccade, rapid eye motion, and it doesn't move. What do you think is going on with that little girl? This is a national boards question. 4. Okay, it's the superior oblique, right? The superior oblique, controlled by cranial nerve 4, pulls that eye medial-inferior. And since you can't activate it no matter what you do, then we know that that's what the diagnosis is. When she fell, she cut that nerve. And when that nerve got cut, that eye had to drift up and out. So what are you going to do to try and see if that eye is hanging out up and to the right? Well, you're going to tilt. And that way that eye is going straight ahead, and you can actually see one picture as long as you got a head tilt, right? What happens if you take her head tilt out? That eye's up in space, and she's seeing 2 different pictures. So in this case, a head tilt, and probably the atlas subluxation that she's getting from it, is protective. Do you want to take away that? No, because then she's blind. Vision is our primary sense. The brain will prioritize anything over vision, because if you can't see where you are, then you can't know what's going on in the world around you, and you're going to compensate. So what do you do now? you send her to the neurologist. This is not a case for you. The neurologist is going to find that cranial nerve 4. He's going to say, wow, that chiro was right. He's a genius. She's going to get surgery. She's going to get that 4 nerve fixed. And then what's going to happen? You're the hero, okay? You're the hero because you caught it, you sent her to the right thing, and you got her to feel better. And that's what this job is about, right? It's not about patient visits, and it's not about revenue, and it's not even about upper cervical care. It's about helping sick people get well, whatever means necessary. And that's what I'm committed to because I value her over what I'm producing, what I'm selling. Does that make sense? Do what's right by the patient, not what's right by you. I left my dogs with my dad while I'm out here traveling right now, and he's babysitting them, so he sent me a picture of my Sabo at home. But, you know, once you know how to look, it's hard to not see it anymore. It's a little up and out. Tuesday. This guy shows up in your office on Tuesday. Now that you guys are looking, do you see any problems here? A few. What's going on? So we got a right head tilt. So it's probably got an atlas problem, right? But is that what's causing it? Look at this skew deviation. When we tilt our head to the right, should this eye go high or low? High, right? Because if my eyes are here and I tilt my head right and this one goes down, I'm seeing double. Normal would be a right head tilt and that right eye is higher than the left. Agreed? Now we look inside his eyes with a fundoscope. Here's the optic disc, here's the macula, and what do we see going on in his eyes? They are rotated this way. Now, with a right head tilt, does that type of rotation make sense? No. If I tilt my head right, my eyes should rotate that way so that the horizon stays level. But as soon as you tilt your head right and the eyes turn that way, what does the world look like it's doing? Tilted. Does anybody know what this type of lesion is called? Good. 1,000 points to lighter. This is an ocular tilt reaction. It's very smart. Ocular tilt reaction is what this is called, okay? It's 3 things. It's a head tilt with a hyperopia on the contralateral side of head tilt and an ocular torsion that is not matching the presentation. When do people get ocular tilt reactions? Okay, so the ocular tilt reaction happens with a peripheral vestibular lesion. And that's what that means is that we have something in our ear called the utricle, and the utricles are kind of positioned like this. So when I tilt my head to the right, then all of a sudden gravity starts pushing the stones this way on the utricle, and that tells my brain that my skull is shifted over here. So it's normal for me to pop that eye up and pull that eye down and rotate that way to maintain vision, right? That's called an ocular tilt reaction. However, in somebody where that utricle is broken on the right side, well, all of a sudden, the right and the left compete, right? The right shuts off the left and the left shuts off the right. So if the right is broken, then the left utricle is always activated. And if this one's activated, when would it typically get activated? When I'm tilting. And what would it do when I was tilting? Pop that eye up and roll them that way. But since it's not, it's just going to do that at rest. Does that make sense? An ocular tilt reaction most typically occurs with a utricle problem. Does everybody in here know what a utricle is? So we have our vestibular system. In our inner ears, we have these little vestibular systems, and there's different canals in these, and the canals activate when we turn our head, and fluid changes, and it tells our head that we are rotating or moving or rotating around an axis. But there's 2 organs, the utricle and the saccule, and the utricle tells you when you're tilting or when you're translating. Saccule tells you when you're tilting down or when you're moving forward. So these are very important receptors in our ears to tell us where we are in space. That utricle fires into the vestibular nucleus, which we're going to get really cozy with today, and that vestibular nucleus fires right up to the ocular motor nuclei to move the eyes. Got it? direct connection. Not only is it direct connection, but look how short this pathway is. Centimeters. It's a very fast reaction. It doesn't take a lot to activate that utricle. There shouldn't be any delay. The second I tilt my head, it should boom, right? But that's only part of it. Because what happens when you tilt your head to the right? You start leaning. So what are you going to do to prevent that lean? You're going to fire extensor musculature on the side of the head tilt. And so that utricle fires into that lateral and inferior vestibular nucleus, goes down the vestibular spinal tract, and activates extensor tone ipsilaterally. Make sense? If we go back, what do you think he's doing? This utricle's firing like crazy because it thinks he's tilting this way since this one's broken. So it's pushing more extensor tone on that left leg, and that's why that shoulder is low, because he's leaning. Okay? Is an atlas adjustment going to correct this? No. No. Wrong. It's a separate problem. And if you, the doctor, keep treating them and they're not getting better, refer them out. It's not the case for you. So what happens is as that utricle comes into that medial vestibular nucleus, the medial vestibular nucleus, the whole vestibular nucleus is married to the cerebellum because the cerebellum is going to refine that information. And where that refinement happens typically is in the middle of the cerebellum. Does anybody know what that middle of the cerebellum is called? Vermis. The vermis. The vermis is called the spinocerebellum because the vermis is going to send projections down to control the spine. I will see different patients with these truncal titubations. If you see a patient with a truncal titubation, guess what's going on with them? Problem in the vermis. So the vermis primarily controls musculature around the spine, but the vermis does some other things as well. The cerebellum, as we're learning over time, processes more than just motor, more than just proprioception. It processes thoughts, okay? The left frontal lobe communicates pretty heavily with the lateral outside border of that cerebellum on the opposite side, and that's why people with cerebellum lesions on the lateral part are going to have speech problems. They're not going to be able to speak smoothly. What do we call it when they don't speak smoothly? Dysmetria. It's verbal dysmetria, where they're stuttering. But the middle of the cerebellum is midline. And when you think about midline structures in the brain, you think they're old structures. And what else is midline and central in the brain? The limbic system, the emotional system. And so what we know is that the vermis of the cerebellum also processes emotion. What does this study say? Evidence from operative series demonstrates that lesions of the vermis were found to be frequently associated with behavioral alterations and executive dysfunction, similar to those produced by disruption of the fronto-subcortical units. So basically, you could have a cerebellum problem and then you look like you're a crazy person and you think it's the brain, but the cerebellum is refining those limbic processes in the frontal lobe in the brain. Isn't that crazy? Isn't that neat? And so when we see children that have problems in that cerebellum, there's all sorts of things with cerebellar abnormalities of childhood that lead to a cascade of abnormal cortical development. Further evidence for functions of the cerebellum has come from examination of cerebellar abnormalities and psychological disorders, such as schizophrenia, autism, attention deficit disorder. Isn't that crazy? You could have ADD or autism or psychosis or paranoia or be extreme because your cerebellum is broken. And what are you going to look for? You're going to look for that hyperopia, right? You're going to look for that ocular tilt reaction. And so Dr. Carrick talks about Van Gogh. He went to Europe and he studied Van Gogh. And when you look at Van Gogh's self-portraits of himself, very often you see a hyperopia on a lot of them. And we know that Van Gogh was crazy. He was crazy. He was a schizophrenic. But what's kind of neat is when you look at a lot of his paintings, like Starry Night, you can almost see the ocular torsion he had. Now, potentially, if I was there, I would have given Van Gogh some right sideward shuffles, turned that utricle on, normalized that vermis, stabilized his gaze, taken care of the the cognitive dyspraxia, and we wouldn't have Starry Night anymore. So maybe it's a good thing, right? Interesting to think about. There may be other people with pathological ocular tilt reactions that is leading to cognitive dyspraxia that's just not being treated correctly. So we need to continue to seek out these individuals and try and help these ocular tilt reactions.
Thank you for that.
I could go on and on, but so let's talk about the vestibular nuclei, right? Here are your vestibular nuclei. Where are your vestibular nuclei getting input from? We already talked about the vestibular system in the inner ear, right? You've got these otoliths, the semicircular canals, the utricle, the saccule. These detect positional changes of the head, and they're going to fire into that medial and lateral and superior and inferior vestibular nuclei. But that's just one piece of the puzzle. You have things coming from your cerebellum, from those vestigial neurons, and near the middle of that cerebellum, that's the output nucleus for that cerebellum. That's going to fire in and give a whole load of information to the vestibular nuclei about balance and where we are in space. You're going to have neurons from the brain, cortical vestibular, coming from the cortex down into that vestibular system, coming from the thalamus and coming from the accessory optic system. And what do you think this coming from the brain is trying to tell the vestibular system? Vision, right? I saw the horizon tilt. That tells you your balance. That has an implication on balance, all that vision. What happens when you close your eyes? Your sway pattern gets bigger because vision is a big part of processing of that vestibular nucleus. Huge. We're going to get into that in a minute. But where else do those vestibular nuclei get input from? The body. Proprioceptive input tells your vestibular nuclei what's going on. And when I lean over to the right and I have more pressure on the muscles and the joints inside that right ankle, that tells my brain that I am leaning to the right. And what is my brain going to do if it thinks I'm leaning to the right? It's going to push off that right leg to get me balanced again. What is that called? Proprioceptive balance system. And it is really, all that information comes together here, talks to that cerebellum, gets refined, comes back out here, and then it starts firing outward from there. 4 components. I need you guys to dedicate those to memory. So let's talk about vision first. Everybody understands how vision works. It's been a long time since school, but we have activation of the retinal ganglion cells. It comes down the optic nerve, goes through the optic chiasm, goes through the optic tract, hits the lateral geniculate nucleus, goes through that optic radiation, and boom, it hits the occipital cortex. And that is where we process cognitive vision, right? That's where what I see, I can actually make sense of what is going on is once it gets to that occipital lobe. But what's really important is that there are little tracts that come off before it hits the cortex. We have a tract coming directly off of that into the hypothalamus. And what is that going to do? It's going to activate that suprachiasmatic nucleus that tells us, hey, the sun's out, time to wake up. Oh, it's dark outside, time to calm down. That doesn't even go to the cognition. That goes straight off of that into the hypothalamus. There's another tract that comes off into the pretectum area, and what that does is pupillary light reflex, right? So it's not like the light comes in your eye and you have to realize you're seeing light and then constrict your eyes. No. Milliseconds. It takes milliseconds for that light stimulus to hit that pretectum, activate that accessory optic nerve, come back out and cause that ciliary contraction. Has to happen quick, right? Those are the big ones that are really important, but the last one is the superior colliculus. And the superior colliculus lives in the back of the mesencephalon in the midbrain, and it creates this map of the world, a visual map. And it says that, hey, I want to look at Fowler, but Fowler is in unit B1. It's like battleship. Shoot the eyes to B1. Boom. That's what happens, right? They contain a map of the world. And so what happens is with this direct pathway here, it is retinal slip, right? If I'm looking at Fowler and my eyes go 2 degrees off axis, he starts getting blurry, and they fire back. They have a quick eye motion back to B1 to correct that to keep him in vision, right? So that's a big deal. Once that vision comes in, hits the occipital lobes, your occipital lobes try and say this is the color of it, this is the shape of it, this is the texture of it, this is how big it is. But that doesn't tell you what it is. So it comes through two primary streams. You've got your ventral stream and your dorsal stream. And the ventral stream coming through the temporal lobes is called the what pathway, right? What am I looking at? Well, it's shaped like that. It's got this black thing on top. Going through the memories, going through the hippocampus in that temporal lobe. Oh, it's a cup. I remember what cups are. That looks like a cup to me. So the what is it goes through the ventral stream. But where is it goes through the dorsal stream, because the parietal lobes have a map, a physical map of the world, right? Where is my arm in space? Where is my leg in space? Where is that in space relative to my body? So the where pathway goes through that dorsal stream. Got it? What they know is that both of these streams have a huge role to play in ADD and ADHD, but also apraxia, right? Because if I say, touch my thumb, and you look at it and you try and touch it and you miss, it's because your where pathway isn't working very well. And if I say, tell me what this is, and they can't say cup because they don't know, they can't process that, it's likely a ventral stream issue. And so it goes through all this processing to try and decide what we're actually seeing. And what's so cool about all of that is that that alone is miles of pathways. The occipital lobes take up roughly a third of the brain. Processing visual information takes up a third of the brain. So by the time I see Chris sitting there and it runs through all those different pathways, by the time I realize it's Chris, I looked at him half a second ago. Vision, what we're seeing, is a half a second in the past, because that's how long it takes to process that. Isn't that crazy? We live in the past. We live in the past, but because it takes time for us to process what we're actually seeing, we have to have reflexes that allow us to respond to the environment faster than that, because that's too slow. So there's going to be eye motions that are voluntary, I call them volitional, and there's going to be motions that are not voluntary, and what do we call non-voluntary movements? Reflexes. Can a problem with vision affect some of those descending cortico-vestibular neurons, create problems in the vestibular nuclei, and end up creating problems in the body and the posture system that's controlled by that vestibular nucleus? Is that plausible, guys? Is it feasible? Can I get a yes? Here we go. So we have a relationship, right? People with macular degeneration. They took a whole bunch of old people that their eyes were failing. They had macular degeneration. They took a whole bunch of people who old people, their eyes were great. And they said, who has more neck pain? And guess what you saw? The visually damaged group had a higher incidence of neck pain and shoulder pain. Why? Probably because their balance system isn't working so well, because they're more imbalanced, because they're blind. And we already talked about that. You think an atlas adjustment's going to fix that? If they're blind? Might help. Could help. But is it the best thing you can do for that patient? No, go get their macular degeneration fixed. Duh. There's more studies out there, visual system disorders and musculoskeletal neck complaints. A systematic review goes a whole lot more into depth on that mechanism. Non-strabismic binocular dysfunctions and cervical complaints. And what do we find when we actually look at the research after an evaluation of binocular function? We conclude that there's a relationship between non-strabismic, right? A strabismus is where your eyes just floating out in left field. Non-strabismic binocular dysfunction and neck pain, right? So if their eyes aren't seeing what's going on very well, they're probably going to have more neck pain. And now you guys know why. Problem with processing of that central vestibular system. The vestibular system, peripheral vestibular system, we've been talking about today, right? We've gone over the semicircular canals, we've gone over the utricle and the saccule, and that fires through cranial nerve 8 directly into that vestibular system. And that's the shortest pathway we have, guys. That's so close. And what it means is that not only is it so close, but it's just one neuron. It's not like boom, 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 boom. It's boom, boom. So it's a quick pathway, and it's the fastest acting pathway. If I shift my head to the right, my eyes are going to go left because of the vestibular ocular reflex. And that's going to happen faster than what I'm seeing, realizing it's moving that way and then moving my eyes that way. It's not fast enough. And if you don't move them instantly, what happens to the world? Gets blurry. What happens when the world gets blurry? What do you feel? dizzy. Is it possible that people with these inner ear dysfunctions can have a problem with central vestibular processing and then an output problem through the vestibular spinal tract to their back? Is that possible? Thanks. Vestibular dysfunction in patients with chronic pain or underlying neurological disorders. It's a big study, but what they eventually found was that people that are having chronic pain that's not traumatically related, all of them have vestibular imbalances. And is it the pain that causes the vestibular imbalance, or is it the vestibular imbalance that causes the pain? Who knows?
Would that include fibromyalgia?
There you go. Fibromyalgia is my next study. Fibromyalgia is associated with impaired balance and falls, right? We find that people with fibromyalgia just tend to have really crappy balance because their vestibular system isn't working. It's causing wind-up in that nuclei, problems with that descending tract, and a twisting of the musculoskeletal system, and potentially dystonias too as well. So yes, there is a relationship between the inner ear and pain. And so if you have somebody and you turn them to the right, and instead of their eyes moving to the left like they should, they just kind of stay right there the whole time, they're having vestibular dysfunction. And do you think it would be in their interest as one of your patients for their neck pain that they're coming in with you to help turn that VOR back on? Yes, absolutely. Absolutely, you should fix that VOR. Why? Because if it's broken, you're going to have more pain. Spinocerebellar pathway. Now, this is where we come in, guys, right? The spinocerebellar pathway. It goes from the spine to the cerebellum, and what is it carrying? Proprioceptive input, right? It's going to take proprioceptive input from the legs, and it's going to go up that ventral spinocerebellar tract on the opposite side. It's going to take it from the upper arm, and it's going to come up on the dorsal spinocerebellar tract on the ipsilateral side, and then the one from the neck is called the cuniocerebellar pathway. And as upper cervical guys just know, cuniocerebellar pathway. This is our bread and butter, because what happens is that when their cerebellum isn't working very well and it's not processing and refining that vestibular stuff very well, then they're going to have bigger sways, and as they have bigger sways, they're going to have more pain. And so as you adjust them, trying to clear their atlas, you accidentally, unwillingly, unknowingly activate this whole pathway, and this surge of input up into that cerebellum on the ipsilateral side fundamentally helps refine the cerebellum's processing. And as that cerebellum heats up, gets better, their balance gets better, and then their neck pain gets better. So this is kind of how it's working, guys. This is what adjustments are doing to people. This is why chiropractic miracles exist. This is why our profession exists, because we are proprioceptive experts. When people have neck pain, either due to a whiplash or they don't know why they have neck pain, they just do, it's going to create problems in the processing of that cerebellum, and they're going to end up having worse balance. Worse balance. So is it the balance that created the neck problem, or is it the neck that created the balance problem? What do you think? I don't know. I still don't know. There's no way for me to know. Which came first, the chicken or the egg? Well, if you fry the egg and you cook the chicken, you have yourself a nice breakfast, you do them both. That's going to give you the highest probability of success, and that's where I want to head, is trying to fix the vestibular problems and fix the cervical problems and trying to get them completely better all the way around. Here's another one, vestibular-related frontal cortical areas and their role in smooth pursuit eye movements. And basically, in human necks, proprioceptive inputs go to the frontal eye fields. Now, the frontal eye fields are up here, and they're the ones that generate quick eye motions, right? So what is going on over there? I want to look at it. This activates first, and it shoots the eyes over there. We'll get through that in a minute. But what they see is that when we vibrate on the neck and we look at an MRI scanner, that frontal eye field's getting a whole lot of input and activation just from cervical proprioception. It plays a really big role in vision. Study kind of proves that vestibular signals alone cannot distinguish between head movements from those associated with truncal whole body motion. And so that's it. If I'm, what's the difference to my brain of this versus this? In this, my visual system shifts left. In this and this, my inner ears activate exactly the same way, but it's the change in muscle length in my neck that creates this proprioceptive change that goes up into the brain, and it helps the brain tell the difference whether my head's turning left or my whole body's turning left. Neck is the breaking factor on that. Huge. Guess who fixes the neck the best? This room does. How to diagnose cervicogenic dizziness, right? And what happens if your neck is all wonky and it's corrupting that vestibular system? You get dizzy. You get dizzy. That's the end cognitive effect of all of this. And so cervicogenic dizziness is a very well-respected medical diagnosis. But if you look at the study, how do you even know that they have cervicogenic dizziness? Well, first of all, it's actually a diagnosis of exclusion, which means you check them for every other thing that could cause dizziness, and if nothing else does it, then we think it's probably the neck. I've got a better test than that. But what this says is some people behind this mechanism of cervicogenic dizziness have suggested that the presence of faulty cervical proprioceptive inputs as a contributing factor. From where? From the upper cervical proprioceptors. I mean, the paper says it, is that when these muscles are all contorted because these bones are all shifted, you're not getting the right proprioceptive input, that's the cause of cervicogenic dizziness. Most likely, because what can also be a cause of it? It could be nociceptive signals from the neck. It could just be the pain. The pain signals are different than those 1A alpha proprioceptive fibers, and those pain signals create a lot of damage in the brain when they're there chronically. Right? There's studies out there that show that people with chronic low back pain for 30 years have 10% less gray matter in their brain. Their brains literally shrink from chronic pain. And so all of this works together into basically these reflexes. The vestibulocholic reflex, right? Well, my head shifts right, I'm going to put out my arm so I don't fall over. That's the vestibulocholic reflex. The vestibulo-ocular reflex, my head shifts right, my inner ears tell me that, my eyes move equal opposite to the left. And what happens if my head goes left and my eyes don't go equal right? You get blurry. I can't look at you. So that's a vestibulo-ocular reflex. But it goes, and then the vestibular spinal reflex is similar to the colic reflex. But it goes the other way. We have a cervical ocular reflex, right? If I turn my head to the right and these muscles get stretched and these get shortened, it's going to push my eyes left. Makes up for vision right there. We know it. It's called the cervical ocular reflex. But the thing is, cervical ocular reflex is a small reflex because the majority of keeping my eyes on that target is the vestibular ocular reflex. When that vestibular ocular reflex fails, my cervical ocular reflex kicks in to make up the difference. That's what they know from the research. But there's, I think, more of a contribution on the day-to-day than they realize. We have the cervical colic reflex. If I bend my neck to the right, it's kind of the same as having my head tilted to the right. Having the neck bent to the right is going to create extension in that ipsilateral arm, ipsilateral leg, flexion on the contralateral side. So here it is. The neck affects whole body reflexes right here. But then the last one is the visual body reflex. And what is the visual body reflex? It's when you're walking in a park and a bird flies at your face, and at the last second you do that. No vestibular input there, no proprioceptive input there, not even any cortical processing there because it's happening. It's that quick. Vision affects the whole posture system. I had a patient come in about 2 weeks ago, and she was severe. She was multiple sclerosis, and so I start testing her convergence, right? Follow my thumb, and every time I do this, she'd do that. Okay? If she pulls back every time a target comes near her face, how well do you think she will hold? Terrible. Do you think it's in your interest as an upper cervical doctor to help fix her convergence that she might hold better? Would that be congruent with your care plan? Absolutely. Absolutely. This falls into our scope. It goes hand in hand with what we do like nothing else does. And that's where we're going to get into, guys. That's where I want to head today. All of this processing ends up resulting in 5 eye motions. Gaze holding, pursuits, saccades, vestibulo-ocular reflex, and convergence. And I want to briefly try and sum up 9 years of neurology in the next 30 minutes. Here we go. So, gaze holding, right? What is gaze holding? Gaze holding is my ability to look and stay on a target, okay? That is a unique eye motion there in itself. Gaze holding is fundamental to every eye motion we do because how the heck can I watch an object move through space if I can't even watch it when it's not moving? How can I look quickly at a target if I can't stop moving my eyes? How do you tell if they have gaze holding issues? You say, look at my nose. and you look in their eyes. And if their eyes are stable, they're probably pretty good. But if their eyes are, that's not normal. That's not okay. And what do you think happens to their neck every time their eyes do that? You see these micro movements in people when you actually look at them, okay? How would you correct those tiny motor problems? Gaze holding exercises. I'm going to try and get to that today, guys. All I need you to know about gaze holding, because I could spend like 16 hours on this, is that there's two major nuclei. It's the INC, the interstitial nucleus of Gogh, helps control gaze holding in the vertical plane. So if they're having eye motions that are jumping up or jumping down, probably a mesencephalon INC lesion. If they're having horizontal gaze holding issues, then we think more of the nucleus prepositus hypoglossae, and I will teach you a really cool way to activate that nucleus to increase gaze holding. This is $1 million question right here. Let's say you're looking at them and they're having these little booms. Okay, their eyes beat downward and then they come back up and fix them. They beat down and come back up. Boom. Call that downbeat nystagmus. What is a likely case that would show downbeat nystagmus that everybody in here knows about? Chiari. Chiari malformations affect the flocculus and the nodulus of the cerebellum, and that results in downbeat nystagmus as a key clinical concept. If you're doing your exam and you keep seeing these little things, start thinking, and they have dizziness, start thinking Chiari. Get them in for an MRI. So $1 million gem that my profession needs to know about. So, like I said with gaze holding, which is most likely in the neural integrator, which is a combination of all those nuclei, there's also a neural integrator for a head motion. And so sometimes I'll ask people to keep their nose on my thumb. And if they can't follow my thumb with their nose, it means that their head neural integrator isn't working. It functions very similarly to the neural integrator that stabilizes vision. That one stabilizes the head. Now, this is where it gets fun, because look, when we have people with persistent whiplash-associated disorders, they got a whiplash, they hurt their neck, you ask them to look at a target, guess what happens? They can't. This study found that in people with whiplash-associated disorders, they had decreased gaze holding. What does that mean to all of my neurology friends out there? They need to focus a little bit closer on the neck. But what happens if you fix the neck and they're still having gaze holding issues and they're having micro oscillations because of it? Then you should address the gaze holding. Not in every case, not in everybody, but in the ones that it's clinically evident, we'll do gaze holding. And it's going to help their neck pain, it's going to help them hold their adjustment better, and that's what it's all about, guys, because I'm an upper cervical guy. The influence of cervical motion on eye stabilization. So what does this mean? They did, I'm pretty sure this is a hypokinesia one. Yeah, they put people in a neck collar for 2 hours, and they didn't let them move their neck. And how do you think their eye motions worked after that loss of proprioceptive input? Not as good. Okay, after a short session, about 60 minutes of that, they found that there's diminished their cervical ocular reflex, but then that got better. And then when they did it for 2-3 hours, then their vestibular ocular reflex stopped working as well. Okay, the neck influences the eyes right there. Neck influences the eyes, and the eyes influence the neck. And if you don't do one or the other, you're not going to miss a boat because they're married. They're linked.
So should I not be putting my patients on a neck collar for 2.5 hours?
That's what I think. That's what I think. And I got another study on that when we decrease cervical motion, we cause problems in the brain because the brain isn't supposed to have the neck like this. And what happens when you adjust people and you tell them never move your head again and they walk around like robots? It decreases your efficacy. It does. Restricting that, creating that fear-based mentality and lacking that proprioceptive is not helping your patients, and I'm against neck collars after studies like this. I'm against it, but that's why we gotta be stable. Eye stabilization reflexes in traumatic and non-traumatic chronic neck pain patients. Exactly what I'm saying. People with neck pain patients had higher cervical ocular reflex gain compared to healthy controls. So what happens in these patients where they're having neck pain? Well, when they move their head to the right and their neck gets stretched, it pushes the eyes too far to the left. Should be a very small reflex, but it goes up when you have neck pain. And what happens if your eyes go too far to the left? you lose vision. You fall off your target, everything gets blurry. You feel like, oh shit, where am I? And your back spasms. Directly related to pain. Pursuits. I don't have enough time to go through all of this today, but if I did, it's basically you have to have a target. You cannot do a pursuit in darkness. You have to have something moving to watch. When they put people in darkness and they said do a smooth eye movement, they just did fast eye movements. You have to have a target. What that means is if you have to have a target, that is going up to the visual cortex. So pursuits are only voluntary movements. There are no reflexive pursuits out there. If they have a problem with pursuits and everything else is working great, guess where the lesion most likely is? In the cortex. Not in the brainstem, not in the cerebellum, it's likely in the cortex if they're only having a pursuit issue. Goes through a lot of different things, the medial temporal lobes, try and tell you again, what is it, where is it? That fires into the frontal eye fields. Okay, I know what it is. What am I going to do about it? I want to look at it. So you're going to go ahead and try and follow that target. That's going to fire through these nuclei in the pontine, which are just really refining it. But that's going to go here into the dorsal vermis. We talked about the vermis, right? So when I'm trying to pursue a target, I need to use that midline cerebellum to follow it. If we have a vermis issue, you can have a pursuit problem. If you have a frontal lobe issue, you can have a pursuit problem. If you have a pontine lesion, you can have a pursuit problem. So pursuits don't tell you where the problem is, but when compared to all the other tests in this big clinical picture, they help you determine where the lesion is. Once you know where it is and you input it and it gets better. That's how this stuff works. So it's going to go through that vermis, through the vestigial nucleus in that cerebellum, into that vestibular nuclei, because all eye motions involve the vestibular nuclei. All of them do. This is more, the flocculus is more of the vestibular part of the cerebellum, not the spinal part, but the vestibular part. That refines that information, goes into that vestibular nuclei. It fires into these gaze holding centers that we talked about to shut them off. So once your gaze are not fixated anymore, you can follow that target moving smoothly in space. So pursuits are a big deal. Now, where does the neck play into this, upper cervical doctors? Vermis, floccula nodulus. All that cerebellar input goes up into there. And so when we have neck problems, we have smooth pursuit problems. Patients with reduced smooth pursuit gains and smooth pursuit gain decrease due to neck torsion. So when you take somebody and you turn their head like this and you ask them to follow a target, that pathway breaks down if they have neck pain. It's decent here, but if you twist them, you accentuate that proprioceptive issue in the neck, it affects that smooth pursuit pathway. Saccade pathway. Now saccades are rapid eye motions, right? Look at my thumb, look at my thumb. Look at my thumb, look at my thumb. That's a fast eye motion. Got it? We do these all day long. 150,000 saccades a day. That's how many we do a day. Boom, 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 boom. You're always generating saccades. I just got to meet my new nephew yesterday. He's about a month old. And guess what system he's working on right now? It's all visual. Just a useless, floppy little body. But his eye movements, he's looking around all the time, trying to get those eye motions better so he can see what's going on in the world. And once he can see the world, then he can move around in it a little bit easier. But that's the first system to develop in babies, is the visual system. That and the GI system. So all they do is eat and poop. But right? We see stuff in the occipital lobes, that's refined. It fires all the way up to the frontal lobes. The frontal lobes say, okay, I know where it is, I know what it is, I want to look at it. So the frontal eye fields are what starts the saccadic eye motion. That fires down into the superior colliculus, which holds those maps, and it says, I want to look at the target in A1, and then the colliculus fires off and shoots the eyes to A1. Okay? Quick eye motions associated are called saccades. There's a lot more that goes into processing of saccades than that. Carrick did 25 hours on this. I could go and go and go. But what do I want you guys to understand? What is the point of this whole lecture? Marriage. Effects of restrained cervical mobility on voluntary eye movements and postural control. Back to the neck collars, Leiter. What they did, they put people in neck collars for 5 days. 5 days they were not allowed to move their neck. Broke down that vestibulocerebellum, broke down the vestibular nuclei processing. How well did they do with quick eye motions after that? Well, when the target was moving at 40 and 60 degrees, Their saccades were significantly reduced. They were slow. They were sluggish. And guess what? When we're doing a quick eye motion, when I'm looking from you to you, the moment that my eyes are moving, that saccade shuts off positional vestibular pause neurons, PVP neurons. PVP neurons tell my brain where I am in space. So when you shut those off during a saccade, it's, oh shit, where am I? And so if you have a really slow saccade that takes longer to get from A to B, you have a longer period of that where am I in space. You're going to have a higher likelihood of balance problems, spinal problems, and everything else we've been talking about today. So you want to get those saccades quick, but when you restrain cervical mobility, they slow down. This is, again, my argument against neck collars right now. I wish Pierce was here, but what else do you see? You see PEMs. Those are pursuit eye movements. Those get really bad when you reduce the neck. And then here's the last one. The variance of body position and vibration-induced body sway was significantly increased. Yes, sir?
What about in the short term, like a couple hours after?
You still see that 1 to 2 hours decreases the cervical ocular reflex, ups the gain of the VOR. Okay, listen, I went and saw an orthospinology doctor on my way out of here just to check out his practice. No collar. Stand up, turn your head right, turn your head left. Good? I'm good. Do they hold as well as we do? Yes. They hold fine. Okay? I would not decrease cervical proprioception because what are we trying to do with our adjustment and by aligning everything? Balance cervical proprioception. It's very important. I would not reduce it. Maybe I'd say take a little bit easy, but listen, this is a big one, guys. Body position and vibration-induced body sway. So when they actually check their body sway and then they vibrate them, they're swaying all over the place after you do that cervical reduced mobility. So I wouldn't recommend that. This is a vestibular ocular reflex. We talked about this a little bit today, guys. I turn my head to the right. This ear gets activated, pushes my eyes equal and opposite to the left. The VOR, it's one of the quickest mechanisms for keeping your eyes on target so I can see where you're going when I'm doing this. And guess when I'm doing this, guys? Do you know when you do this? When you're walking, okay? When you're walking, you got these little tiny head motions, and that VOR is going to help you keep it. So what happens when you got a patient that comes in, they say, I'm fine unless I'm moving. As soon as I start moving or turn my head, I get super dizzy. Guess what do you think is their problem? Probably the VOR, right? So then you test them, okay? Right? Because what's happening when I do this and I get super dizzy? Well, everything. The eyes are telling you that the world is moving. The neck is telling you the world is moving. The ears are telling you it's moving. So you say, okay, what if we just spin you in a chair to the right? Okay, now you're taking the neck out of the equation. Still dizzy, doc. Probably not the neck. Okay? What about this? What if you say, look at my target and keep your head on the target, and then you do this, and they start getting dizzy? Now what's going on? What's happening there? It's all cervical. It's got to be cervically mediated. I think that having the head fixated and rotating the body under it and seeing if it elicits dizziness is a true method for ruling in or out cervicogenic dizziness. But rotating them in a chair and them getting dizzy, more likely to be vestibularly mediated. Rotating them in a chair with their eyes closed, taking vision out of the equation, more likely to be vestibular mediated. Got it? Not moving the neck, not moving the ears, just saying, look at my finger, and I'm super dizzy from that. Visually mediated. Follow? We can break it down if we're just better clinicians. Guess what happens? And then convergence. I don't want to spend a lot of time on convergence because you guys are all tired. I'm tired. But basically, convergence is cool because convergence doesn't take lateral motion of the eyes. So you not have to engage that lateral rectus, which is in the pons. You only have to do those medial rectus, which is coming out of the oculomotor nerve up in the mesencephalon. So convergence is really more of a mesencephalic test than any of the other ones. And what happens if you say, follow my finger in, and that right eye comes in, but the left eye can't follow it? Probably a left mesencephalic problem, not activating that medial rectus properly. But guess what? Then you say, follow my thumb here, and their pursuits are working good. Different pathway, different means. So we compare these different eye motions together to give us one big picture. And what happens on convergence when the neck is turned? It gets worse. In pain. People with neck problems have worse convergence. So what does this mean? It means that the eyes are related to the neck, and the neck is related to the eyes. And which one are you going to fix? Both. I'm so proud of you guys. This is it, right? This abducens nerve is cranial nerve 6. That's going to activate the lateral rectus. It's going to fire up through the medial longitudinal fasciculus to hit the oculomotor nerve, to hit the medial rectus, to move the eyes that way. And while you're trying to get that final eye motion pathway going, there are so many different things fighting for it. You got your vestibular ocular reflex coming in, you've got your gaze holding coming in, you have your vergence centers coming in, you have your saccade centers coming in, and they're all competing for a piece of the pie to help determine the final outcome. That's how it works. I've been studying it for like 9-10 years. I'm not even close to fully understanding it, but I had a concussion case this week. Okay, this girl flew in from Colorado. She had a concussion 3 years ago where she slammed the right side of her head. She has tried hyperbaric chamber. She has tried chiropractic. She's tried acupuncture. She's tried every herb on the planet. She still feels like she has no idea what's going on. Her balance is terrible. Her eyes are jumping all over the place. And what did we do with her? I saw her 3 hours a day for 4 days. That was it. 1 week, 4 days, we're just doing, let's refine out that pursuit pathway. Okay, that's looking better. Let's make sure that vergence is working better. Great. All right, how is your vestibular ocular reflex working? Let's get that working better. Great. So we rehabbed all of those different eye ones, whichever ones weren't working, we rehabbed a couple hours a day, and by the end of Thursday, just 80% better. It's crazy. Because what happens in upper cervical? Well, healing takes time. Wait. Longer. You think they want to wait? No, they want relief yesterday. There's more at our disposal to help refine all these vestibular systems. And we can do it through eye motions. We can do it through head-body motions. We can do it through adjusting. And depending on where the problem is, it's going to take a little bit of everything. So it's possible. It's doable. Keep studying. Gaze control. So what happens when we totally take them out of space, right? We put them in space, astronauts. What's going on when you're in space? Do you have good proprioceptive input? Terrible. Do you have good vestibular input when you're in space? None. How about visual? How's vision when you're in space? There's no horizon. It's impaired. And so what happens to astronauts who spend exposure in microgravity? Check this out. When they took them out of gravity, or microgravity, took them out of space and they started looking at their eyes again, everything was broken. Amplitude and velocity characteristics of gaze control, including smooth pursuits, saccades, and gaze holding, were significantly decreased. Total reaction time, how long does it take you to see that bird flying at your face, realize it's a bird, and move and dodge? That's reaction speed. And he covered reaction speed this morning, right? 2 to 3 times the reaction speed. You're way slower after spending time out in outer space. Gaze holding ability was degraded, and like I said, gaze holding is like the fundamental common pathway between everything that's going on. And for several cosmonauts, smooth pursuit was collapsed. They weren't able to follow a moving target at all. So what did? They did saccades. They went boom, 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 boom. And what happens when you're doing a lot of saccades? Shut off those PVP neurons, lose your position sense, increase your balance, sway, hurt your back, get dizzy. Smooth pursuits were completely collapsed. You ever see what happens when they come out of space and they take them off the shuttle? They don't let you, right? They put them away. They don't let people see them when they come off the shuttle. Why? Because they're messed up. They're really messed up. We're human beings. We're meant to be on Earth. We're dependent upon gravity. I really just fundamentally don't think long-term space flight is ever going to be a possibility until we create artificial gravity. Now you know why. So, clinical gems. Do you guys want to do some clinical gems? Or do you want to go home? Gems? I could if you let me. Let's talk about cervical proprioceptive training, repetitive peripheral somatosensory, blah, 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 blah. So, cervical proprioceptive training. Guess what that includes? Chiropractic. When you adjust somebody and you reduce a misalignment, you increase their alignment, you balance out muscle spindles, you improve proprioceptive input up into the brain. So fundamentally, chiropractic is cervical proprioceptive training. But there's more than that, right? they did this research where they took people with neck pain and they split them into two groups. One was a traditional physical therapy approach to neck pain, craniocervical flexion exercises, chin tucks. Chin tucks are actually really good for neck pain, really good for reacting, turning these muscles back on. They're usually shut off after whiplash. Do your reading on chin tucks. Heck of an exercise. But they compared it to groups that were doing joint position error training. How are they training their joint position error? Well, we use this in our clinic. It's something called motion guidance, and it typically involves strapping a laser to the head. And so what do? All right, so look at this right here, right? I want you to get that laser right there on it, okay? Now close your eyes, turn your head to the right, and then try and turn your head back there with your eyes closed so that the laser is right where it started. And they open their eyes, and the laser is here. And they realize that what they thought was neutral is actually a little bit of right rotation, and that visual feedback helps them correct that. And so that's basically what they were doing, was helping train your awareness of what right rotation is, what left rotation is, what up and down, using these head lasers. And guess how that group did with the head laser compared to the chin flexion group? The results suggest that improved proprioceptive acuity following intervention with either exercise protocol may occur through an improved quality of cervical afference, input, or addressing. So basically what it's saying, it says that both work, but the joint position error group actually did better. It's neat. It's neat. I think this is such a good combo with upper cervical. Honestly, something like getting a stinking $10 laser, strapping it to their forehead, and having them trace patterns. Like we have these big charts, and it's like, trace the pattern with your head. And as you do that, you get this visual feedback that helps correlate with your cervical proprioceptive things. You get a better awareness of where you are, where your neck is in space. That refines all of the pathways we've been talking today. And guess what that's going to do to their neck pain? It's going to help. That's a big one we do. RPSS. So do you guys remember me talking about the nucleus prepositus hypoglossi today? Yes? Everybody does, clearly, right? What does it do? Stabilizes gaze in the horizontal plane. So what happens if you look at my target and their eyes are doing this? Their NPH isn't working. What happens if you try and do a pursuit and it's going, the eyes are jumping around on the horizontal plane? Probably a lesion in the nucleus prepositus hypoglossi. So there is a really awesome way to stimulate that, and it is through tongue stimulation. Okay, that's what it says in this research. Electrical tongue stimulation normalizes activity within the motion-sensitive brain network in balance-impaired subjects, as revealed by group-independent component analysis. And basically what they were doing was they were using a little unit like this. We've got a couple of them hanging around at the clinic. We set it to a 3. We hit a train of 4. Stick out your tongue and Take a big breath. Stick out your tongue. Dunk, 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 dunk. Check their eye motions. All of a sudden, their pursuits are leveling out. Guess how their neck does when their pursuits are doing better? Relaxes, right? Because what happens if your pursuits are choppy and you're trying to follow a target? You're going to move your head along with it. But if your pursuits are working and you can do these horizontals, your neck relaxes. They're married. They're married. Pick one of these up on Google. If you see somebody who has really terrible lateral or horizontal eye motions, stimulate their tongue. It's going to go great with what you do as upper cervical doctors. It's definitely not going to throw them out. So I don't think it's quite the same. You know what's also cool about this unit is we use it all the time in migraine, right? What we'll do is we'll put it right here, and it's going to stimulate that branch of that trigeminal nerve, and that's going to feed back into that trigeminal nucleus, and it actually helps rehab that trigeminal nucleus. So it's actually a really great modality for anybody with face pain. Just put it right there. People with carpal tunnel will put it on the wrist sometimes. Again, it just depends where they're going on, but this is a really common tool we use. It's worth its weight in gold. Gaze stability, right? So what happened in older adults who had dizziness? They gave them gaze stability exercises. And guess what happens when we took the group? We had gaze stability exercises. We had a control group. We gave them different types of gaze stability exercises. There was a significant interaction for fall risk as measured by the gait. The GS group demonstrated a significantly greater reduction in fall risk compared with the control group. Gaze stability in older adults reduces their fall risk. That's exciting. What's probably doing better if your fall risk goes down? Your balance. What's your balance connected to? Everything. Are you guys seeing the pattern here? So gaze stability is going to help reintegrate the nucleus purposivis hypoglossi, the interstitial nucleus of Gogh. It's going to help them hold a target. It's going to help with all other eye motions doing that. Guess how you do gaze stability exercises? Look at a target about arm's length away, focus your eyes directly on it, and do the slowest no you can. Close your eyes, take a big breath. Let's do another one. So we'll do no-nos, and we'll do yes-yeses with 80 to 90% of my patients. Start with gaze stability exercises. It helps them keep their eyes on a target. What happens if you can't hold your eyes on a target because your eyes are jumping around? Your head jumps around to try and stay on it. How well are you going to hold if your head's jumping around all the time? Not very good, okay? These are the most powerful thing I could possibly teach you guys is how to help their gaze improve, and we do it through very slow no-nos, very slow yes-yeses. I'd probably have them take 16 seconds just to do one yes. Super slow.
I had a patient I gave that to, and she said, oh, I tried that before at the PT office, and it really didn't help. I just said, how are you doing it? And they had her doing it really fast.
Yeah.
And I was like, why don't you do it slow?
Gotta go really slow. There we go.
Yeah.
Gotta do it slow.
It was weird. She was like, they wanted me to do it really fast.
I think we just went through it. I think it's Edgar's law, basically, but the slower you go, the more you're going to be firing that vestibular ocular reflex to help refine that. But with the gaze stability, you're also taking visual information because you're going slow enough that your brain can process the vision, what you're seeing. You're combining it with the cervical ocular reflex. You're combining it with the cervical ocular reflex. And you're integrating all of them together to try and rehab that pathway. So I could spend a whole lot more time on the small interactions of it, have them do it. If it makes them feel worse, have them do it seated. If it makes them feel worse, have them do it laying down till they can get to seated, and then have them do it standing up till they can do it without problems, and then have them do it while they're walking. And if they can do it while they're walking, then they can walk down the street without getting dizzy. Pencil push-ups. All right, so there's not a lot in neurology that if A, do B. Very rarely does that happen, except for pencil push-ups. Convergence insufficiency is something we talked about. You try and follow a target. If your eyes can follow it in and they're not jumping around, that's good convergence. But if one eye doesn't come in very well, that's called convergence insufficiency. Normal convergence is about 4 inches. You can see here without it getting blurry. I had a patient last week. I said, tell me when it gets blurry. There. Terrible convergence. You know what her #1 chief complaint was? She couldn't read. You can't read. When you can't get your eyes together because that mechanism's broken, everything looks blurry. And then guess what happens when you try and read and you try and converge? Mesencephalon fails. It brings all those pain-inhibiting programs to threshold. You get a headache. That's what her thing was. So we worked on pencil push-ups a lot this week. Follow my thumb. Tell me when it gets blurry. Right there, doc. Pull it out a little bit. Focus, focus. Okay, it's clear. Come in a little bit. Yoke it all the way out. Close your eyes. Take a breath. Do it again. Lots and lots of pencil push-ups. These are proven in the literature to help fix convergence insufficiency. If you can fix just convergence, they can read all of a sudden. Please do your reading on pencil push-ups. Very well recognized exercise, very effective. Some people don't do as well with push-ups because their parietal lobes are damaged, so that smooth pursuit isn't working very well. So what are you going to do? You're going to use what you got. What do you got still? You got your frontal lobes. What do the frontal lobes do? Rapid eye motions, right? So Brock string is another tool we use where it's a long rope with beads on it. You hold it to your nose and you look from bead to bead to bead. So now we're going to work on that convergence insufficiency with rapid eye motions. Okay? You can get Brock strings on Amazon for about $5. Really great exercise. So let's say somebody, the right eye isn't coming in very well. The left eye is doing no problem, but the right eye isn't able to yoke in very well. I would have them do rightward eye push-ups to create more abduction, adduction of that right eye to exercise that mesencephalon a little bit better. But what happens if you try that and they start feeling worse? It means that nucleus is too unstable to exercise it that way. So try them from the left, because left is going to work on gaze holding to the right eye, bringing it inward the whole time. So you work on those till they become more stable, then you work on these to strengthen it, and then once you do that, you give them these as a take-home because you want them to be able to do everything midline in the end. So, gold.
Sunny in California.
It's beautiful. I'm in Santa Barbara. I work at ImagineX. This is my view into this gorgeous plaza. This is a church we're in. It's about over 100 years old. This is all the original stuff. And this is what I call my neuro gym. You know, and in the neuro gym, we're going to be doing different types of exercises, either doing gaze stability, doing motion guidance. This is D2 right here. This is a motor reaction training board to increase their motor reaction time, which is always impaired in concussion. This is a tilt table that we'll do to help rehab blood flow in and out of their brain as they're changing gravity. And then guess what we always do at the end of the day with these patients? Adjust. We adjust. Because that adjustment has a big piece of the puzzle right there. We check them and adjust them. And right now, I'm kind of limited to traditional chiropractic because I don't have my instrument set up. You know, when I get the instrument set up, hopefully in a couple of weeks, then I really plan on marrying upper cervical with functional neurology because I fundamentally think that this is going to be the very best rehab for these people in the end, and that's going to put me out of two other people in the world trying to combine them. So if you guys you have any questions for me, this is my email, joshsilverdc@gmail.com. IXNeuro, ImagineX Neuro is our website. If you're having like a migraine patient or a concussion patient, they're just not getting better, and then you try some eye stuff and you don't know what you're doing, they're not getting better, have them call us because we do 1 week intensives. They fly in, we treat them every day for a week, and then we send them back home. And I've had some unbelievable patient cases in the last 3 months, just unbelievable recoveries happening in 5 days because you know what? Yes, healing takes time, right? Muscle healing takes time. Bone healing takes time. The brain changes like that. Right? How much did you guys learn today? Those are instant changes in your brain that we just made. That's neuroplasticity, and that's what we do. We drive neuroplasticity. The last one is a shameless plug, but check out Advo Accessories. This is where I make all my cool adjusting toys, playing back into the upper cervical arena. So.